Good afternoon, team. Myself, Zuhaib Ahmed, the junior data analyst at Vital Care Medical Center. I'll walk you through today with the data-driven performance review. Now, Vital Care is a regional provider of managing thousands of patients across multiple facilities with the complex operational needs. Our analysis gets into the depth of the patient records 55,000 covering the demographic, diagnosis, clinical admission, and the billing data. This analysis is important for improving the patient care, reducing the operational cost, and optimizing the resource allocation. These insights help leadership to take the strategic decisions for the further growth and improvement of our organization. To frame this entire analysis, we have come up with 5 important questions across the various segments. First is the demographics, which patient group drive the highest admission and total operational cost. Most important. Clinical urgency, which medical condition are most expensive and how does the admission urgency affects the outcome? Which hospital and insurance partner shows the highest cost and longest patient stay? And what specific factor leads to the extended hospital stay across the vital care network? And how does the clinical test predicts the longer stay and the higher overall cost treatment? Considering these 5 questions, we have built the entire dashboard using the data, which has KPI monitoring, conditional analysis of various medical conditions, and interactive filtering and slicing for a efficient user interface. Now, if we go through, we can see we have 56,000 patient record. The average billing is 25.5K USD. The average length of stay is 15 days, and the percentage of emergency patients which are high focused are 32.92. If we see in the breakdown, the highest prevails is the urgent, then next comes the elective, then comes our emergency. Whereas if we consider urgent and emergency are a similar kind of operation, which takes around 66% of it. And if we see our operations, the diabetic treatment prevails the highest, followed by obesity, arthritis, hypertension, asthma, and cancer based on the billing. If we see which month has the highest number of patients admitted in our facilities, we can see a very upward trend from April till the month of August. Then there is a small downfall, which becomes a very linear growth. Let us go deep dive into the clinical insights where we can answer most of our questions. We can see the highest adults takes the highest, whereas in adults, females take the highest, and next come the geriatrics, which are 65 plus of age, in which female takes the prevail, and next comes the male, and the pediatric is the lowest. Whereas there is a very contradictory approach here, whereas geriatrics comes in the mid of the things, but they are the highest cost deriving operational cost impacting age group. If we see here, the cancerous patient, the patients with the cancer and emergency has the highest stay with highest average of 15.76 compared to the normal average of 15.56. And even the number of patients get admitted are very high in the cancerous patients compared to any other, compared to hypertension, diabetic, or asthma. If the test cancer, sorry, I had a filter, so cancerous takes the highest, next comes with the thing. If we see the average length of stay, that is question number 5, how it impacts. If we see the inconclusive has the highest billing and the normal reports has the longest stay, because we know there is a disease and impact, so the stay becomes higher, but the cost becomes lower, whereas inconclusive has the less stay, but the highest billing. If we see We have answered another question that based on the age group, the adults take the highest, whereas the cost deriving are the geriatrics. In the cancerous takes the longest urgency, which is answering question number 2 of which. The average length of stay, if we see, is the highest comes around 23 days and the lowest comes around 2 days for the least doctors. Here it shows for the top 10 doctors, it's just 4.5. Now, if we see across the multiple condition, let us go through the cancer. We see the highest is 28 days and the least is 9 days. That says that cancerous patients stay more when compared to average, that is 15, they stay for 28 days. That is approximately double. Here, even the key influencer says the admission type when it is emergency, they are bound to stay 1.04x, that is around 14% increase in the stay. And even we can have a look that the cancerous patient, the results are abnormal stays contributes to the highest stay. Now let us deep dive into the financial analysis. We can see if we remove the hospital filter, we can see the Medicare has the highest billing amount, followed by Blue Cross, then followed by Athena, and so on and so forth. We can see the least hospital is Johnson PLC, with the highest comes to the Smith and Sons, with the highest coming to the Smith and Sons. Or our hospitals see an increasing. The average billing highest is in the hospital Hands Morton, with the average stay of 14 days and the average billing going up to 52,000 USD, which is almost the 2x of the general. Now let us see Hernand's Hospital, Hernand's Morton, and Morton, which disease prevail. We can see cancerous is the highest. By this, we can say that cancerous and the urgent patients comes are very nominal, and United Healthcare provides the highest billing of them. By this, we could answer that cancer urgent becomes a major operational overhead for us, even for the patients. By going through a very quick overview of this analysis, we have found insights like 50% of the patients. Let me share the entire screen. 50% of the patients who are 65 plus are the highest cost demographic, and the 50% the volume of 33% emergencies derives the highest. And the cancer admitted patient, which we saw, has 22 days on average time, twice as the facility. The highest cost hospital, it's 2.3x times, that is Johnson's PLC, and Smith and Sons has a variance of 2.3x. If we see the one more answer, the abnormal tests, the normal results compared to abnormal results increase the stay duration by 45% and the cost by 31%. Considering this, we have come up with the strategic recommendation divided into clinical program and operational excellence. First, launch a comprehensive management program for diabetic, hypertension, and arthritis, which derives the highest in some hospitals, and protocol, implement uniform evidence-based treatment for cancer and diabetics and across all regions. Operational excellence, especially renegotiate with the high-cost insurance provider, Medicare and Blue Cross, and data integration for the light data tracking. And focusing on reducing the cost variance to coming up with a very linear approach. Now, for the immediate action, we can implement a high impact oncology care from day 1 to 30, are developing a rapid response team and a protocol implementation and a pilot expansion in which deploying a rapid care team and embed cancer specialist, and specially discharging becomes a bigger challenge compared to other diseases, 48 hours, and pilot expansion across all the hospitals, starting with 2 hospitals. This target reduction reduces from 22 days to 19 days within first quarter. Now, this reduction from 22 to 19 days have a positive impact of 4.2 million annual saving. which is for our operational cost, even for the customers, patients reduction. Now, how does to implement all our 5 recommendations? Leadership buy-in, the capability building for real-time data analysis, the IT infrastructure to implement real-time data analytics and success metrics, which can be monitored to establish a culture of continuous improvement and transparency and accountability across patients and operational success. Now, leveraging the data and predictive modeling, we can implement the segmentation of hospitals to get a normalized impact and readmission tracking, which is lacking as of now, the geographical analysis and the capacity management, which can be done. Based on this analysis, we can go through the more details. Thank you.